The idea is that if you're a patient that qualifies, and to qualify, essentially these are heavy smokers we're looking at, those that are at high risk for developing lung cancer. So you might go into your doctor and say, okay, I saw a commercial that says, heavy smokers qualify, I'm the right age for this, well, what about me? And I think a lot of these conversations, they talk about the benefits and the harms of screening to try to reach a decision together, the physician and the patient, about whether it's the right thing for them. And the harms that are often discussed are the typical things that you talk about with CT scans, like radiation. Another thing is there's a lot of false positive results in lung cancer screening, so people might think for a number of months that they might have lung cancer when they don't actually, and they find that out by going back and having another scan, and that doesn't show any growth in the tumor, for example. The main benefit that they discuss is early detection, which means catching the tumor earlier. And the idea there is that if they catch it earlier, then they might be able to actually intervene with surgery or radiation therapy and cure the patient, where that's not so much an option later on when the tumor grows and spreads. Now, what we're trying to do is inform that conversation about early detection benefits. So the thing is that right now, when we talk about early detection, we assume that it applies to all patients equally, that everyone's equally likely to be able to go on to surgery or radiation therapy and derive the benefit that comes from that. But in reality, patients are very different. And so we're trying to come up with a way to actually quantitatively and systematically figure out what their risk is, or what their probability is of having bad outcomes after surgery or radiation therapy, because that's what their doctors will think about down the line if they were to find early stage cancer and evaluate them for treatment. And so we're putting numbers to this, and the idea is that if we do that right, then those numbers can actually come into the conversation between a physician and a patient. So instead of saying, well, on average people might have benefit from early detection, we might say, well, you might have a 10% chance of dying within 30 days if you had surgery, because you're older and you have more comorbidities and things like that. Whereas the next person that comes in the office might have a 1% chance of dying within 30 days of surgery. And that additional information can help patients and physicians make better decisions about whether screening is right for them. So that's really what we're after. We're trying to introduce some new information that can help patients and physicians have a better conversation about whether screening is right.